Thank you very much for the introduction. I would like to thank the organization committee for the kind invitation to perform this lecture today, in particular Paula Alba, Guillermo Ponce-Estel, and Maria Laura Bertolaccini. Thank you really for the invitation. I will talk about cardiac manifestations in antiphospholipid syndrome. I have no disclosures related to this lecture, and these are the topics that I will discuss with you today, just now. First, the valvular heart disease, as noted before, is the cornerstone of the cardiac manifestations of the antiphospholipid syndrome, APS, and it requires the presence of antiphospholipid antibodies and mitral or aortic manifestations. Which valvular abnormalities can we see in the APS cardiovascular manifestation? First, the mitral valve may the thickness of the mitral valve, of the leaflets, and also the presence of nodules in the atrial phase of the mitral valve or in the vascular phase of the aortic valve. Of course, it is necessary to exclude infective endocarditis or rheumatic fever to diagnose a valvular heart disease related to antiphospholipid syndrome. The other abnormality that we can find in antiphospholipid syndrome is the Liebman-Sachs endocarditis. The yellow arrow here, the yellow arrow here, the yellow arrow is in a mass in the mitral valve, so this is a Liebman-Sachs endocarditis, and also the red arrow is a thrombus in the right atrial cavity. In 2016, we reported a case of a patient with an embolic stroke and also a valvular disease, and we found in this patient antiphospholipid antibodies, and we diagnosed the Liebman-Sachs endocarditis, obviously excluding infectious manifestations. How frequent is valvular involvement in APS? Is not precisely defined, but it could be seen between 30 to 60% of the cases, depending on the series considered. But when we observe sleep patients, we can observe that valvular manifestations, valvular heart disease, are much more frequent in APS patients compared to non-APS patients. Which are the risks related to valvular heart disease? First, the formation of thrombus in the atrium. Second, the embolization and the development of a stroke, as we noted in the slide before, and other central nervous system manifestations such as migraine and epilepsy due to microvascular thrombosis and endothelial damage. Second, the ischemic heart disease. We know that APS could provoke coronary thromboembolism, accelerated coronary atherosclerosis, hyperlipemia, and arterial hypertension. These lead to acute coronary syndrome, myocardial infarction, or other ischemic complications. In the well-known series of Professor Cervera and Professor Yehuda Schoenfeld of thousands of patients observed during 10 years follow-up, they observed that between 1 to 5% develop valvular thickening, vegetations, and myocardial infarction. But when they observe the risk of death related to myocardial infarction or stroke is much more higher than the prevalence of the disease. So we have to take in account, to keep in mind that myocardial infarction and stroke is an important cause of death in APS. To estimate the risk of, to stratify the risk of cardiovascular factors, Sabino and Maria Laura Bertolaccini developed a score, the GAPS score. This publication is in rheumatology with patients with lupus, and they include in this score the antibodies against the prothrombin and phosphatidylserine complex. And they observed that a cutoff over 10 may predict a risk of cardiovascular events. This is the adjusted GAPS score in patients without lupus, and where they exclude the antibodies against phosphatidylserine prothrombin complex, and they observe that hyperlipemia, lupus anticoagulant, anticardiolipin antibodies, and anti-beta-2 GP1 antibodies are more frequent in patients, in young patients with APS who develop myocardial infarction regarding to the other who not develop myocardial infarction. Third, the ventricular dysfunction is well known that is more frequent in right ventricle than in the left one, and it may provoke diastolic or systolic dysfunction due to microvascular thrombosis, intramyocardial arteriolar immune deposits, fibrosis, or left ventricular hypertrophy, as noted in this slide. Atherosclerosis in APS is frequent, and as you can imagine, all systemic autoimmune diseases increase the risk of atherosclerosis, and APS is not an exception. So, atherosclerosis is more frequent in APS patients compared to patients without APS, as reported in this meta-analysis, and the subclinical manifestations of atherosclerosis are also more prevalent in antiphospholipid syndrome patients. So, to sum up, atherosclerosis in APS multiplies by 2.5 the risk of carotid and femoral plaques, and also increase the risk of subclinical atherosclerosis. Finally, pulmonary arterial hypertension. It was reported recently by Ignacio. The recurrence of deep vein thrombosis lead to pulmonary arterial hypertension, and it is worth to note that antiphospholipid antibodies are the most frequent condition associated to thrombotic pulmonary arterial hypertension, as noted in this study reported here, where antiphospholipid antibodies increases by 11 the relative risk of thrombotic pulmonary arterial hypertension. Finally, how to manage these conditions? First, an aggressive control of cardiovascular risk factor is always necessary. Aspirin, if cardiovascular risk factor plus antiphospholipid antibodies or systemic autoimmune diseases are present, in particular sleep, the use of statins improve endothelial function and decrease oxidative stress. The use of hydroxychloroquine is mandatory in lupus patients, as all you know. The valvular heart disease may require surgery, so an opinion of a cardiac surgeon could be necessary. The use of corticosteroids to reduce leaflet thickness is a topic of debate, is a topic of controversy. As you know, I'm not prone to use corticosteroids in any manifestation, but there are some reports interesting regarding to this topic. The chronic anticoagulation if pulmonary arterial hypertension is also necessary, and anticoagulation with vitamin K antagonist if valvular heart disease and systemic embolism is also mandatory. The use of direct oral anticoagulant is still looking for their place. They are still looking for their place, and this will be a topic of another session with Professor Pengo and Professor Cohen. and I will not talk about this topic. Finally, I have to thank everybody for your kind attention.